Good evening. I'm Dr. Brian Andreas, Chairman of the Clark County Board of Health and the Vice President of the Kentucky Association for Local Boards of Health. I want to thank all the Board of Health members that are participating across the state tonight. I appreciate the presenters who are with us. We have a full agenda, but we believe all the information is vital for you as Board of Health members to hear and hopefully understand so that you can make informed decisions regarding the future direction of your own local health department. I want to thank Allison and everyone that did a lot of work. My suggestion of a tropical motif in the background just apparently was not have been a good idea. But before I hand it over to the first speaker, I want to say a few words about KALBOH, or the Kentucky Association of Local Boards of Health. If your health department is not a member, I would encourage you to join. A lot of benefits to membership. It includes dual membership in the National Association of Local Boards of Health. I've had the opportunity to attend a couple of the national conferences, and you'll come away with a lot of ideas. It really kind of pumps you up attending those, and you get a chance to interact with other people and see what's being done around the country. KALBOH has also purchased access to a web-based Board of Health member training that is excellent. I'd also say that the CADA website is a good place to go to if folks haven't for information about running the Board of Health. There's a lot of resources there, and unlike a lot of websites where you end up kind of searching for something that's supposedly there, it is prominently marked down at the bottom. If you're interested in becoming a member of KALBOH, please contact us. We're in need of leadership as well as members, and always looking for new people and new ideas. Before I turn it over to our first speaker, I'd like to remind you, if you have questions, to email those questions to the email address that's on the screen. And without any further delay, I'm going to turn it over to Dr. Eager from the Kentucky Retirement System. Thank you.
Thank you. I wish I were a doctor. I'm not. Not PhD or otherwise. We had a bit of a technical snafu, so we intended to have the presentation up so you could see it. We don't have that. I will tell you the presentation I'm going to go talk through, and you'll get a copy of this later, is a presentation that we gave to the Public Pension Oversight Board in December relative to the quasi issue. I'd start by, this reminds me of a time back in the 1980s when I was doing consulting work for the District of Columbia Retirement System, and I was speaking at a conference in Washington with about 600 people, and I had my presentation was supposed to be Federal Express to the Washington the Washington D.C. retirement system, and it was, but they couldn't find it. My first experience with government, and sometimes how government works, but I started my talk off, if any of you can remember the old FedEx commercial back in the 1980s where they would say, "It absolutely has to get here"? Well, that was the way I started my talk, was by saying it absolutely was supposed to get here, but it didn't. But we'll be all right. We'll get through this. This presentation started, the gist of it started back in the 2018 legislature when House Bill 362 was passed, which provided for an opt-out process for quasi-agencies to get out of the Kentucky retirement system. Essentially, the process was that we would determine the unfunded liability, we would allow the agencies up to 40 years to pay for it, and it would be effectively an interest-free loan. So all the agencies would have 40 years to pay. They would have no interest payments during that period of time. So we were extending a loan for 40 years at no interest. The effective cost to the KRS was about $2 billion. So if we had been able to invest those assets rather than let them out at no interest, so about a $2 billion cost, we protested. It's unfair to all the other agencies that remain because they would have to pay it. It would cause their own contribution rates to go up by 6 to 8%. Not fair. And the legislature recognized that. The governor actually vetoed the bill. The bill came back and was passed, but that provision for getting out over a 40-year period was taken out of the bill. But what was put into the bill was to say, KRS, you come back by December of 2018 and you tell us how this ought to work. And so we formed a task force. Budget Secretary Chilton, who's on our board, our head of legal counsel, our head of operations, and myself, 4 people studied this. How are we going to deal with these quasis? We studied it throughout the course of up until December. And we looked at everything. Could we buy out individual members? And just the bottom line, it doesn't work. Could we shift the quasis out of the K plan into the C plan and let them pay the differential between the funded rate, about 13% for K and 50% for C? And that wasn't going to work. I mean, C wouldn't take the agencies because of the risk associated with it. So we looked at a lot of different aspects. And when I showed up to make this presentation to the PPOB, I said, and anybody who was there will remember this, I actually repeated it this week to another group, I said, we're trying to pull a rabbit out of a hat. And if you know the analogy, and I said, we looked in a whole lot of hats. I mean, we really did. We pursued all kinds of methods. The bottom line is there is no rabbit, and there's not a good solution. But where we are now is contribution rates were based on a change in assumptions made in 2017, beginning, as many of you may know, beginning July 1 of 2018. Contribution rates for most plans, most agencies went up by 50%. So in the K plans, they went from 49% to 83%. And the belief by the legislators, and they listened to quasi agencies, is quasis can't afford that. So the quasis, as you may know, were frozen at 49 for 1 year, for the year beginning July 1 of 2018, frozen at 49. I have pretty good insight that it'll get another year's freeze, so there'll be protection for 1 more year. At least there are legislators who are proposing that. But the bottom line, we call it a conundrum. The bottom line is the agencies can't afford to pay 83%, and there is a process by which agencies can leave the system currently in place. It was under House Bill 351 in 2017. The cost to get out is, in a lump sum, is prohibitive. So if an agency has a liability of, pick a number, $100 million, that'd be a big agency, but 10 million or 5 million. In most cases, they can't afford to. So we call it the conundrum. They're caught between a rock and a hard place. Can't afford to go to 83, can't afford to get out, so what do we do? And so in our presentation and proposal to the Public Pension Oversight Board, we had 3 alternatives. Let me actually turn to my page so I can make sure I cover all the bases here. By the way, there's another problem going on that I'll allude to, and that is, and this is a broader problem, but it affects the quasis. Most agencies are paying 83% right now, and they pay 83% of their payroll. So collectively, we get 83% of the entire payroll of those agencies. What's happening is several things, but the payroll is going down in size because, primarily because the agencies are reducing their workforce. So we have, for example, Western Kentucky University outsources 165 people in their maintenance. Another university outsources 200 people in their food service. So when they outsource these individuals, their payroll goes down. So in order to maintain the system, we have to raise the rate. So in all likelihood, the next rate's not going to be 83%. It's going to be, I don't know, 90%, 95%. What that's going to do is encourage more people to not hire people who retire or who leave or to outsource. And we call it kind of the death spiral. Payroll goes down, rates go up. Rates go up, people outsource or reduce their workforce. And so you'll hear, hopefully you'll hear a lot of talk, and we're talking about it a lot, and I think it'll pass, but there's something called fixed dollar funding, and that means let's just stop for the moment. Let's take all this unfunded liability, let's set it over here, and let's assign it to each of the roughly 1,500 employers that we have in our system. Let's assign a specific liability to that each of those agencies, and they pay that on a fixed dollar basis over a 25-year period. We're almost saying this is a mortgage, and you're going to pay a fixed dollar. So whether you outsource or hire, that doesn't change. That's a mortgage payment we're going to get. And I believe we're going to get that in the 2020 legislature. I see very little resistance to it. We're talking to a lot of people. So that's part of the way to get out of this conundrum on the rising rates as workforces shrink. But it's a year away, and it's not a done deal. But for the interim period, we came to the Public Pension Oversight Board, and we said, you know, there are no rabbits, but we have 3 options. Option number 1 is have the quasis go to 83%. Have them pay the full rate that everybody else does. The advantage to that is it's equitable for all the other employers. All the other employers eventually have to pay that shortfall. That shortfall is about $132 million. So by paying 49% instead of paying 83%, in aggregate for all 118 quasi-agencies, it's $132 million. Nobody put that 132 in. The state didn't step up to do it, so we shorted our system $132 million. We're probably going to do it again next year. It's in all indications. Now we've had 2 successive years, $132 million. Our actuaries say can't do it a third year. If you try to do it a third year, we're going to build it back into the rates and raise the rates higher. So we kind of have a 2-year potential hiatus, but it's going to have to be solved after that. But our first option was go ahead and do it to the 83%. The advantage was everybody's paying the same. Nobody's getting a break, if you will. The disadvantage is to probably force bankruptcies. So we force bankruptcies. Now, again, we're losing employees, we're losing contribution, and we're potentially losing services. I didn't mention that this conundrum between can't pay the 49 and can't afford to get out. Every time we say that, we say the state wants these agencies to. They need the services of these agencies. It isn't just like, let them go broke. There's a real sensitivity to that. But disadvantages, likely cause bankruptcies. The remaining employers eventually are going to have to pick up the tab for that $132 million. So you're shifting liability, responsibility that belongs to the quasis to agencies that, in a way, don't deserve to take it on. The states, again, will lose services if agencies do go bankrupt. And we actually may end up with, if we go to 83%, we may end up with less money than we at 49 because of losing agencies that are contributing. Option 1. Option 2, continue on for at the 49% rate. We suggested that we fix dollar that. So if an agency we're essentially saying let's take these quasis and put them on a fixed dollar basis on the liability that they have. Let them make their payments at the rate the 49% is, whatever that is, and let them pay for as long as it takes to pay off that liability, which might be 40 or 45 or 50 years, potentially. But they say they can pay the 49, let's let them pay the 49, but do it in a different fashion. Again, that shorts the system by $132 million a year, but there's no optimal solution here. They're all suboptimal. The third was, and they still might go bankrupt. There's another disadvantage. Maybe, in fact, we could get 55%, not 49. We get some more money. We don't know where that line is. We have no idea where that line is. The third option, which was suggested, some of the legislators said, let's come up with an option where there's skin in the game, so that the quasis have. So they put skin in the game too, kind of a shared sacrifice, or however you want to call it. And they said, KRS come up with something. Well, and they, in fact, suggested what the something might be. And the something might be would be to say, all right, beginning July 1 of 2019 or 2020, all new employees go into a Tier 4 defined contribution plan. And we're going to reduce the cost going in. In fact, there could be a negotiated arrangement whereby all employees went into a Tier 4, but I wouldn't get overly excited about that. But the savings by doing that are so minimal that we just don't think that's a reasonable option. So we came back and we talked with our board, and we kind of I don't want to say we punted, but we came back to the legislature and said, keep them at 49 for another year, move the whole system to a level dollar, and try to work out the funding on that with the quasis over a long period of time. That's, I don't know if you've got questions here internally. I'll tell you, we feel your pain. We also feel the pain of 1,500 other agencies. KRS is funded at 12.9% right now. So if you want to equate that, I use savings for college education as an example. You can use the home mortgage or whatever, but I say, all right, I had a child born today, and I know at age 18 I want them to go to college, and I want them to go to the University of Kentucky, and I know it costs $20,000 a year today. It's probably going to cost $25,000 a year when they're age 18. So I need $100,000. I need to save $100,000. So I start saving. I don't save as much as I should. I have a budget to get to 100, and I assume I'm going to earn some money on my deposits in my little brokerage account or wherever. I have many years where I don't put in what the budget said to put in. I'm told back in the 1990s, in fact, one governor took money out, borrowed money out of the system. I don't have that factual information. That's anecdotal. But it would be like saying, I'm going to take some money out of the college fund because I need a new car or a new furnace or something. And the comparable is, now my child is age 13 or 14, going to go to school at age 18. Instead of having $100,000, I have $13,000. And what are you going to do? How do you solve that problem? Considering the analogy, the inviolable contract, you can't say, well, you're going to go to junior college, you're not going to Kentucky. Well, we have an inviolable contract with that child that says that child's going to the University of Kentucky. I might say with the next child, well, you're going to community college, but I can't say with that child. So it's all about the dollars. We need massive amounts of dollars to come into the system. It's $27 billion underfunded. We are $27 billion in behind where we should be in terms of funding. The investments aren't going to get us out. When you have $2 billion in investments, $2 billion in investments and $15 billion in liabilities, somebody says, well, gee, if we could earn more, do a better job managing those investments, it doesn't move the needle. I joke Warren Buffett could run this money for 40 years and we're still going to be in a deep hole. The investments just aren't there. So we don't lobby for tax increases one way or another. We lobby for money. We let the legislature decide where the money's coming from. That's up to them. But it's a big number, and it's going to put a lot of pressure on the state budget. It's affecting the credit rating on bonds, which has another cost that says if credit ratings go down, the cost of borrowing money goes up. So tremendous amount of implications here. I spoke to the Kentucky Education Association, 300 or 400 people a year ago, and my message was, gee, you're all in the teachers' retirement plan. Well, most of them are. There were some bus drivers and others that are in our plan, but most of them are in the teachers' plan. Why would you even be interested in listening to somebody from KRS talk about the K plans and the C plans and the state plans? Why would there be any interest? And the point is, you're all taxpayers, and this is a burden on the state of Kentucky that's it's got to be managed. I mean, there's no question about it, but it's going to be painful. I don't know if you all want to prompt questions here.
I don't know if there's any questions. I have a question. Could you talk more about the level dollar fund?
Sure.
A little bit more example of what that means.
Yeah. Here's the example, and the mortgage is a good place to talk about that. I'll give you an example. Let's say I'm making $50,000 a year, and I do a budget, and I figure I can afford 20% of my income to fund a mortgage. And I pick a house out, and I go to the bank, and the bank says, oh, fine, we'll approve you. The mortgage payment's $1,250 a month. And I think, well, 20% of $50,000 is $866 a month. So I say to the banker, and the banker wants $1,250 straight line, 30 years. I say to the banker, I'll make you a deal. I'll give you 20% of my income for the next 30 years, and I'm going to be making more money every year. So what I'm paying you is going to go up every year, and I'm assuming that my income is going to go up by 4%, which is what we've assumed for a long time with payroll. So in year 10, I'm making $72,000, and in year 10, 20% of my income is $1,250 a month. So I'm up to where I'm supposed to be, and I keep making more money, and I keep paying the banker more, and I make up for the shortfall, and everybody's fine and happy, and we're good. The problem is my income doesn't go up 4%, it goes down 2%. So I go from 50 to 49 and so forth. After 10 years, I'm making $42,000, and 20% of that, it converted into a monthly payment, $667. So I'm not paying $1,250, I'm paying $660. It's exactly where we are. So level dollar says, let's figure out what the debt is, $27 billion. Let's figure a uniform, in this case, 25-year payment, like I have a mortgage. I'll pay that payment each and every year, regardless of where my income is. That's as simple as I can explain it. It's a must. I mean, we're in deep, deep trouble if we don't do that. And I think the legislators get it. I haven't had. They may get a hiccup when we do the initial transfer, because we do the initial transfer, cost is going to be a little more. And undoubtedly, it's going to be a little more than it is currently. But it's the only way out of this problem.
I have one more question for
Sure.
you. When you calculate the level dollar, will it eventually go down because seemingly liabilities will go down? Or
Yeah,
is that...
sure. So there are two components to the payment. The 83%, about well, in the pension case, about 9% is what's called normal cost. That would be, if you had no unfunded liability, that'd be what cost to run tier one is 9, tier 2 is a little less. Tier 3 is 3%. Once we are through that 25-year period, that payment is gone. I paid off the mortgage. I own the house. We don't have to make that payment any longer. All we have to do is make the payment that covers the normal cost of operations, 3% for tier 3. So you go from 83 to 3, plus the cost of insurance. We got to add that in there too. So today, if I hire somebody to pay them $50,000, I got to pay $41,500 in pension. 25 years from now, well, even the year after level dollar is in effect, I hire a person, I pay 3%. So I'm not dissuaded from hiring. That's what's happening. Nobody wants to hire anybody because it costs so much. We get that level dollar set aside over here and start paying it down like a mortgage, and you hire a person, it costs you practically nothing. So there's no incentive not to hire. I mean, it's actually going to be good for agencies to be freed up, but that's still got to be paid.
Okay, we have one more question
from the field. And the question is this: I've been made aware of an additional option where retired folks would be put in their own system and funded. We would only be responsible for actively working staff. Is that still on the table?
No. If I understand it, they're saying, repeat the question again.
I have been made aware of an additional option where retired folks would be put in their own system and funded. Workers, I guess, agencies, quasis, would be only responsible for actively working staff. Is that still
well, I don't know what you do, how you can only be responsible for active working staff when 70% of the liability, well, it's only about 60 with the quasis, of this $27 billion overall in all the systems, 70% of it is for retired people. I mean, that's what has to be paid. So setting up a new plan for active employees doesn't do anything to get rid of that. And that's why when people say, well, we're putting a tier 4 that's going to solve this problem, that $27 billion is still $27 billion. It still has to be paid. A tier 4 defined contribution does nothing to eliminate that. I mean, we're stuck with it.
Yeah, my guess from the question would be make somebody else pay for the retire that group.
Yeah, I'm open to introductions. I'll take a meeting anytime, anywhere. And the state can't do it. I mean, the state. You talk to the state, and I tell the state, hey, we're 132 million short, 49 versus 83. How about writing a check? And No way. We don't have the 132 million to do that. We were already stretched as far as we can go.
Okay. So if there's any other questions from the field, we will put them all together and send them to you,
You bet.
Mr. Eager, and I know you'll answer them for us.
You bet.
I appreciate you coming
Well,
and your transparency with us and our Board of Health members across the state. So
Yeah, and you'll get this presentation.
yes.
Our door and my phone are always open. If you got questions, call me. If I can answer them, I will. If I can't, I'll redirect it to somebody else. And we want to be as open and transparent as possible. So thank you.
Thank you very much.
Good evening. My name is Mike Tuggle. I'm with the Department for Public Health, Division of Administration and Financial Management. My presentation on the agenda tonight is labeled the financial state of local and public health departments. Really, I think we probably could have named that more along the lines of the financial crisis of state and local public health departments in light of the increased pension costs that David has just referred to in his presentation. What I want to present to you tonight is something more specific to the county health departments and kind of give you an idea of what our landscape looks like across the state as far as our county health department system. If we have the slide before you, would be a map of Kentucky. You should be seeing that map. As you look at that map, you know, again, I used the word crisis earlier here, and you know, in all my 20 years of serving in the state public health department and having responsibility for both the state finance side as well as the local health department side, as a role of mine, I have never seen in my time, in my 20 years of serving, a situation whereas we have our state health departments, and look at this map as being those counties represent each of our county health departments and our county health centers. So think about those counties that's plotted here on this map, especially the ones in red and yellow. Those are being identified as our county health centers or county health departments. Never in my time have I seen a map that would look this way with the onset of a cost that's coming your way. The reds and yellows, those indicate your solvency. Health departments that are looking at being insolvent over a period of up to 24 months. The reds, of course, indicate those that have a survival of perhaps only 12 months. The yellows further indicate those that could survive up to maybe 24 months. And what that means, survival is financial survival in the midst of the KRS pension cost increase. So essentially 64 of our county health centers and or health departments would be nearing insolvency and not operational with this increased cost that David talked about as a more global, but mine's going to be more specific. Let's go on to the next slide, and the answer is why. Why is our state looking like that? Why are health departments failing? And again, based upon this KRS cost increase we've just talked about earlier with Dave, you heard David talk about, we're going from that 49.47 factor up to the 83.43 factor. What that means to our county health departments across the state, as you can see here, in FY19, our cost for that pension cost with that 49 factor is roughly $50 million for our state health department system as an aggregated amount. FY20 with that new factor being put in place, and as David said, it may be delayed until FY21. That would mean $88 million of cost, or an increased cost of $38 million. Again, in my 20 years of service, I have never seen a cost be placed in our county health system in 1 year of $38 million. Again, I refer again to that agenda. Crisis is the word that should be used. We're in the midst of that. The KRS increase, is not new. So let's be fair on that. It's not a new cost. This cost has been around, as you heard David say earlier, it's been around for years. And this slide right here kind of indicates to you of some of the history. And I went back to 2006. Now, if I'd given you a map and a bar graph a little larger than this one, many years prior to 2006, it was at that flat amount of 5.89%. So there wasn't much change up to 2006 for the many years prior to that. And I do this in increments of every 2 years, you'll notice, because that's where the state gets funding. That's where the state receives its funding, is through a biennial budget. So you can see that each 2 years where that factor has grown over time. And you can just seamlessly go across over to 2019. You can still see that factor at 49.47%, which was the 18 rate for our local health departments. As David pointed out earlier, that 49.4 cents was a reality based upon a waiver in House Bill 265 that allowed those quasi-entities to be given a 1 year of reprieve from that 83.43. As you can see, FY20 in the budget bill, it does have a cost of 83.43. And again, that would be eligible, and that's the current law today. Local health departments would be facing that 83.43 without some type of 1 year of additional reprieve, as David points to legislation being in place to hopefully give that 1 year. But again, the facts are that is not the case. The facts are that July the 1st, 2019, local health departments will see an 83.43% factor. 5 months that cost by law is in place. We're hopeful legislation will change that, but again, I'm speaking from a fact. So what's new? So we just saw the slide that showed that there are increasing costs, and we've seen costs going from the 5.89 up to the 49.47 today. So what's new? That increase of that 83.43 is not funded. Thus, the challenge is that our county health systems, I'm putting this map back again to show how does it get funded. There's a source of funds called unrestricted reserves, and that's what that map's kind of depicting here. It's not just a map without purpose of saying what does the red and yellow mean. It would all be red. Let me just tell you, it would all be red if we didn't have unrestricted reserves for use. But because of unrestricted reserves, you can see the white counties are going to survive beyond that 2 year period of time. They're going to survive beyond the 2 year. Some of them maybe 2.5 years, some of them 3 years, some of them maybe 4. But for those red and yellow, using their local unrestricted reserves that your health department has, they would deplete those reserves. Within the first 12 months, the reds would be out of business, even using those reserves. The yellows again, the yellow counties would be maybe up to 24 months and no longer a health center in Kentucky. Again, I use the word crisis, not a financial state, it's a financial crisis. So let me now talk about some of the assumptions built into this model. We've talked about, roughly 64 of our Kentucky counties without a health center or a health department. So to get to that, we've talked about KRS being the driver, that 83.43 factor. Some of the assumptions using this was that the impact was based on current KRS calculation methodologies. As David mentioned in his earlier presentation, that there's legislation to hopefully change some of the pension and to make some of the rules differently. But again, that's not the case. And even some of the things that he had discussed is still not a solvent model. It still will not identify new revenues for the county health departments. It will not change anything more than burning down those unrestricted reserves that they have to take care of things like disasters, emergency, and even outbreaks, which we dealt with here recently with Hep A. So it depletes that, even with changes, because there's still going to be cost, high cost, to do this. Another assumption was that FY20 salary cost will have to be no greater than those used for this analysis. FY19 salary costs, budget salary costs for counties were used for this analysis. So if those salary costs were to go up any, then obviously the red counties become more red. the yellows become red. Even the whites maybe become yellow or red because costs would be higher and reserves would not be any more. Another assumption is that KRS costs will be the only cost driver for FY20 or a future year. In reality, that's not the case. Typically year after year, one of the drivers I see is an insurance cost, another employee benefit called health insurance. Those continue to go up. It's not driven by necessarily the county health departments. It's just the mandated cost of doing business. The assumption also is that all other costs remain static for the county health departments. So outside of just a KRS driver, it would say that everything else, employee benefits, other employee raises, cost of doing business with other entities, those would all remain static and not put a higher burden on the health department. That's not likely. Costs go up. Utilities costs go up. Space costs go up. Living costs go up and gets passed on to vendors and providers. Another assumption is also that FY19 unrestricted reserve used will be available for support of the KRS cost, excluding what was budgeted for FY19. Again, that's not likely either. There will be another drain against those unrestricted reserves besides only the KERS cost. So that's another challenge. A last thing here I've used as an assumption was unrestricted reserves is the only source of local funding. So when we looked at this and plotted that map, the only new revenue to help fund this cost are local dollars. There are no additional state dollars. There's no additional federal dollars being passed through to the counties. So what this means is that are there other local monies that could be available to support this? Well, the assumption was used here was only unrestricted reserves. So if there happen to be other dollars used, that could help soften it. But again, unrestricted reserve is what the county health departments have available, and that's what could be used, but that's all that we have that could be used at this point. Now, I've put this slide in here just again show of those red and yellow counties to give you an idea of how we've calculated and how we came across to say, how did you get on the map as a red or yellow? And so what we looked at is what is the salary cost of those counties that made the red and yellow on the map to say, what is their salary cost that would be eligible for KERS participation? What would that new factor, going from the 49 to the 84 factor, what would be that new cost, which you can see in that second column of data? Then you can see what's the unrestricted balance currently that county health department would have, and then how many months based upon the cost could that reserve take them. And you can see the first three lines of that report. I talked about up to 12 months of survival, red counties. Well, in that first three lines, first three rows of information, that's a total of 9 health centers, 2 districts, 1 single county, for a total of 9 health centers or local health departments that provide services in communities. You can see day one, forget a month of survival, forget 2 months of survival, they're negative because they don't have unrestricted reserves. And that's the only source of money available for those counties to support that. Again, there's no new state money available for counties. There's nothing in the bank. There's nothing in federal grants. So with this cost is being placed in our county health departments with the idea that they have the only source of revenues to cover this cost. And that is a fact. There's no additional money in Frankfurt to do it. Not in our budget, not in any other budget at this time. So again, you can look through that. Again, if you're in the red or yellow, this is the data for your particular county. Again, in the far right column, it does show the months of survival. And up to that 24 months, you'll see. So again, you can see we're in a dire situation, a situation that's out of your control as a local health department and a board of health officer, because these are state costs being borne by the KRS system and being pushed down to you. So it's not something we can wait to take actions on. This is something we've got to hurriedly take action on. And as we know, while there's legislation that may be proposed and different laws that may take place to assist with this, there's still going to be an effort required of each of our local health departments to continue to participate at some rate of cost that's beyond their means to pay for. And this is on the perspective of a financial officer that's, again, served for 20 years. I've never seen a situation this dire. So I would encourage you to take this as a serious message tonight And if you have questions, please make sure those get sent, and I'll get those answered for you, okay? Thank you all for your time.
Thanks, Mike. Any questions?
You have it. Well, I'll be able to see my slides here, correct?
Just give him a nod when you want to change.
Okay, good. All right, good afternoon, everyone. I'm Dr. Jeff Howard, the Commissioner of the Department of Public Health. It's a pleasure to be here with you today, and the message so far has sounded pretty grim, I think, across the board, and I hope to be able to lighten it, the mood a bit, to talk about what we can do to fix this situation and what I believe is a real opportunity to change public health and public health outcomes across our entire state. I come to you today in complete honesty and transparency, believing that this is truly an opportunity to transform a system that has needed transforming for many decades. That's not a value judgment on the efforts of anyone in the past, but is a statement regarding where we're at in public health today. And based on the feedback of you, boards of health members and executive directors running our health departments. So with that being said, I'm going to go through a very abbreviated version of the slides that many of your directors of public health have seen. And we're going to talk about from the very basics of the issues we're facing today, which you've heard some about. And then we're going to move on to some generalized solutions. Then we're going to get into some specifics about the way I think we can transform this public health system and turn it into something that works for Kentuckians. Next slide, please. The motto of this process is truly simplify, focus, and prioritize. That's what our public health system needs. We've been an inch deep and a mile wide for 3+ decades, and we've got an inch deep and a mile wide worth of results. Next slide, please. On this slide, I'm going to talk to you a little bit about what I think about public health. And these disclosures are truly me just disclosing to you my viewpoints about public health and what it should be, and in some ways, what it shouldn't be. But first and foremost, I believe every Kentuckian should have access to a high-quality public health product no matter where they live in the state. I believe that we have to be accountable at all levels of the system. That includes the State Department of Public Health, our local health department level, our local executive director level, and even our Board of Health level. We all have to be all bought in, and we have to be working together in a concerted effort to improve our public health outcomes. I'm also committed to ensuring that we are doing and using the best public health practices that are available to us, and that includes practices that are evidence-based rather than haphazard judgments, which do occur sometimes in this system, and I have witnessed them personally as I've visited health departments. My perspective in considering this transformation is not that of a state Department of Public Health or a local Department of Public Health, but it is all of us together as a system and how that we can work together to improve our outcomes. I want to clear up one thing really quick with the next bullet point. Is my goal in this transformation was not to take away local power. It was not to force everyone into regions, as many people surmise, but rather I'm significantly committed to our shared governance structure. I think it makes us unique. I think it presents us with many opportunities. So what you won't hear is an effort to force people into regions or districts or to centralize our system in which is completely controlled by the state. In fact, I think you'll see quite the opposite throughout this presentation. And lastly, I believe that our public health problems and solutions exist locally. And what that means for me is that I don't think the state needs to be trying to drive our solutions. I think we need to be looking to our local health departments and local health officials to drive our solutions. Next slide, please. So the goals for this transformation are simple and fairly straightforward. First is to relieve the physical instability that is facing our system. You've heard today we've got $38+ million that we have to come up with to fund our public health system. We really need to introduce a more modern, more simplified, and more focused public health model that is in line with the Post-Affordable Care Act and Public Health 3.0 principles that hopefully many of your directors have been talking about over the last several years. In line with the statements I made earlier, I want to create accountability at every level of our system and improve our public health leadership capacity throughout, which is a bullet point that came from our directors and boards of health who have told me on my many visits throughout the state that we need greater leadership in public health at all levels. Number 5 here you see is preventing duplication, effort, and duplication of efforts and reducing red tape throughout our system. We have lots of duplication of efforts. And that's not just with our health departments, but it's our health departments with our communities. Oftentimes, we're trying to offer services that other people in our communities are also offering. Sometimes we're even in direct competition with local hospitals and private providers. And that's really not our role. Our role is to complement and support. And given this difficult financial time, we really can't afford to do that. And then lastly, I want to really support those data-driven and evidence-based best practice outcomes that will really drive public health in Kentucky. Next slide, please. So first, I'm going to go through this briefly because you've heard about this a lot, but our first real challenge that we face in Kentucky is up to 42 health departments possibly facing financial default in FY20. That is 42 health departments who are on the clock beginning July 1 of this year. That deficit is created mostly by the pension issues. We're going to talk more specifically about that in a moment. But our biggest expenses outside of what I'm going to define as core public health, what I believe is the most important public health services we offer, are our clinical services. And that's a reality we all have to face. Next slide, please. This is a map that you saw earlier on Mr. Tuggle's slides. I hope each of you look at this and look at the counties that you are living in respectively and that you represent. Is your county in red? If so, you got less than 12 months from July 1 of this year. If it's in yellow, you have less than 24 months. And if you're in white today, let me tell you, this crisis is coming to your doorstep soon. This is sort of the rising tide that we use that phrase often, the rising tide that rises, it brings everyone up, but this is actually something that's coming to sink us all if we don't address it quickly. Next slide, please. So how do we get here? And we really got two driving factors that brought public health to this crisis point. First is the Affordable Care Act. That's not a value judgment on whether the Affordable Care Act is good or bad, but the reality is it changed the makeup of public health both in Kentucky and across the country. Earlier, Mr. Tuggle referred to the biggest public health deficit he had seen in his career, and that happened when the ACA and Medicaid expansion occurred in Kentucky. Our budget was cut by $12 million, and local health departments laid off 300 people at that time, and the state health department structure shrank as well. Also, with the ACA, is our patient makeup changed. Those people who were coming through our door to get indigent health care no longer come through our doors. Rather, they're insured in a medical home, and we're happy for it. But we have to realize that public health cannot be the same in the post-Affordable Care Act era. Second is Kentucky's pension crisis. And we've heard so much about this already, I won't go into it, but it's created almost a $40 million deficit in our system. These are the driving factors. These are the burning platform that require us to change. If not, we will not have a public health system 5 years from now. You will not have a local health department if we don't make drastic and serious changes. Next slide, please. But at the same time, as we have this financial crisis, we also have to acknowledge we haven't had the health outcomes that we want in Kentucky. And that's a fact that we cannot ignore. That is not to say that we haven't done some really great things. That is not to say you and your health department has not done really great things and moved the needle on some areas. But overall, we're ranked 45th out of 50 states. Next slide, please. And since 1990, we've only been above 40th one time. That was in 2008. We've always been in the bottom 10 states in the country for the last 3+ decades. And that's something we need to change. Now, there's a lot of factors that cause that. And again, it's not to say that any one person or any one health department hasn't done a good job. But as a state, we have not been able to move the needle on health and health outcomes. Next slide, please. But again, in the same vein, this is not your fault. I want to present you a quote from Earl Conway and Paul Batalden from the Institute of Healthcare Improvement in the Harvard School of Public Health. And that quote is, "Every system is perfectly designed to achieve the results that it gets. Our system is designed to achieve bottom 10th ranked results. And so we need a system that is designed to allow us to achieve the results that we want." And I think this is an approach that will give us that. Yes, it's more accountability. It's more accountability for me as a commissioner of health, and it's more accountability to you as representatives of local health departments. But if we're willing to embrace that, I truly believe that we can change the health outcomes in this state. Today we rank 26th in per capita spending on public health. We spend middle of the road dollars and get bottom of the road results. That has to change. And us, me and you, as stewards of the public health system, cannot stand by and let that happen anymore. Our taxpayers, our citizens, the people we represent deserve better. Next slide, please. So carrying on with the rest of the problems that we face in this system is number 2, and I think this is the most important. And I take the blame for this. And that's that our current programmatic services are not truly reflective of the community needs. What I mean by that is you have not been able to identify the needs of your community, the public health needs of your community, and address them appropriately. And there's several reasons for that. But one, and the most important reason, is that we have a directed public health system. What I mean by directed is that we have from the top down pushed the agenda, rather than having what I consider an emergent public health system. That is a system where our priorities can emerge and grow from the grassroots. That is from the local health department level. So what I'm going to propose to you today is a system that, yes, introduces some accountability, but allows local health departments, allows you to drive the agenda. It allows our problems, our priorities, and our solutions to emerge from the local health department level. And so you'll see more about that later. Third is we really have some legislative issues we need to clean up. Public health law in Kentucky is expansive, and no one really knows what all it means. Currently, right now, I have someone working on this matter, and we'll talk a little bit about that in a moment. And then fourth is our shared governance structure. It's a challenge. Now, I told you I'm committed to it, and I am. But it is a challenge, and it's a challenge because I have to get all 61 of you to agree to this transformation. We don't make decisions without each of you, and so I'm asking for your commitment, your support, your friendship, and your partnership as we move through this transformation. Next slide, please. So in general, here are some solutions that I think that can help us address these problems. And again, these are general solutions, but I use this general platform to inform the transformative process I will describe momentarily. First, for our fiscal instability, we have to simplify, focus, and prioritize. The same model I mentioned earlier. What that means is that we cannot continue to do everything we're doing today. We can't be an inch deep and a mile wide. Rather, we have to simplify, we have to focus on our core priorities, and we have to prioritize. What that means is, again, every program that you're doing today, you may not be able to do tomorrow. But hopefully we can focus our spending, our efforts, create economies of scale, and really target, like a laser, the issues that we can really move the needle on. And as such, move the needle on health in Kentucky as a whole. For number two, for our programmatic services not reflective of our community needs, we have to be accountable and transparent. The state has to be accountable. I, as your commissioner, have to be accountable. But you, as local boards of health members, have to be accountable. And you have to hold your director and their staff accountable to addressing public health needs. Something else I really need to do is define our roles throughout the system. What I've learned over the last year is sometimes we don't know which lane an issue runs in. And so we have to clarify. So there's no guesswork between the state, the directors, and boards of health. For our legislative issues, I've already told you, we plan to simplify the public health legislation and make it easier for everyone to understand now and in perpetuity. And for shared governance, that structure where we share power with you, where the state shares power with the local boards of health, if we're going to get over the issues that can hamper us, because if anything's going to cause this system to fail, it's the mistrust that has to do with shared governance. And so what you have to trust is that I'm being honest and open with you, and that I'm being accountable to a standard. I have to trust that you're being open, honest, and accountable to a standard as well. And if we can do that, we can trust one another. So that's what I'm asking you to do in the true spirit of partnership. I do also want to increase our leadership abilities like I've discussed earlier. And I also want to support our local boards of health greater than we ever have in the past. I want to make sure you have the structure and the education capacities that you need to be active and participatory boards of health and to support your directors as they need so that you can really move the health needle in your communities. Next slide, please. So, the system we have developed is before you. And what you'll see first is the basic components are what I call core public health. Now, I know that phraseology has been used in the past, but I redefine it here. And I think core public health consists of really four things. First is our foundational public health, which is made up of 5 components. 1, population health, which I will define in a moment. I know that has many definitions and connotations. 2, enforcement of regulation. Those are things that are already required in statute, and we have regulations to enforce. Those are things we have to do. You're already doing, and you have no choice to do them because the law says we have to. Now, we may be able to change some of those in our public health law reform and transformative process, so there may be some tweaks there. Third is emergency preparedness and response. I think we can all agree that that is a key role of public health in our communities. Fourth is communicable disease. Think things like hepatitis A outbreak. That's always going to be a role of our public health system, or at least I hope so. And fifth is our administrative and organizational structure. What is new here in the foundational bracket is the community health assessments. For those of you who don't know what a community health assessment is, it's where you as a health department will lead a strategic process of identifying the health priorities, public health priorities of your community. This is the absolute cornerstone upon which I'm building this transformative process. It must be done, and it must be done well. You should be doing it already, and we should all be held accountable to that standard. This system requires that, but it also supplies funding and technical assistance to do that. Second program, that I think should be absolutely included is WIC, our Women's, Infants, and Children's Food Program. I think it's absolutely vital to our public health system. Third is the HANDS Home Visitation Program, and then fourth is our harm reduction, our syringe service programs. I think those are absolutely vital, and I think those four things encompass what should be available to every Kentucky citizen from public health, no matter where they live. I want to reiterate what I mean by core public health and what the implications of that are. It means these four things, these four categories, will be available to every Kentuckian in every county in Kentucky, the counties that you live in, to every Kentucky citizen at a very high level. You guys have probably heard the language do or assure. In the past, the Department of Public Health has required you guys to sign a master agreement, which required you to do or assure every program on that. That practice will end, and I know that comes at as a happy turn of events for many of you. These will be the only things that are do or assure in the future of public health in Kentucky. And they're the only things that I think are absolutely crucial that we must do because no one else can do them. But I'm okay with community partners offering these services. Right now in the Louisville metro area, we have outside partners who are offering WIC and HANDS. I'm okay for that to happen in your communities if you don't believe that you can run these services efficiently. But what I do want you to agree with me on as boards of health members is that we agree we have to do these foundational services. They're absolutely the foundation of our system, and that WIC and HANDS and our syringe service programs, because of the magnitude of substance abuse in our state, are so crucial that we're going to make sure they're available. And say you find someone to do that WIC service for you, and that partner were to go away, I need you to agree with me that we'll pick up those services at our local health department until we can find someone to do that. I think that isn't too big of an ask. I think we can agree that these programs are absolutely vital to our Kentucky citizens. So that's a fairly simple, that's just 4 programs. Many of you are probably thinking, what about everything else in public health? Next slide, please. And in my mind, everything else is local public health priorities. These are the priorities that you guys identify. When I say that this is an emergent system that emerges from the local health department level and trickles up to the state level, when I promise you that I'm going to let you guys define the state's public health priorities, here's how I'm going to do it. By letting you guys identify local public health priorities. Next slide, please. These are some snippets taken from other Department of Public Health websites across the country. And what you see is that all of them are trying to focus in on community health and developing healthy communities. We're going to be the first state to jump all in. We're going to jump into the deep end of community health and focus on community health in a way that no other state has done. We will be an absolute forerunner and a model for the rest of the country if we can continue to agree and push this process forward. Next slide, please. So, this is an emergent system, not a directed system. So if there's a couple things that stick in your mind at the end of this, is simplify, focus, prioritize, and emergent, not directed. Next slide. This slide will give you a little bit more information about our foundational public health system. These are some of the services that will be incorporated. And for those of you who have been around a few years, this shouldn't surprise you because this is a snippet from what has been colloquially called the People Paper, which was written by Allison Adam and Georgia Heiss and some others 4 or 5 years ago now, and was voted on and supported by CADA as a core foundational service. So this is not really anything new. It shouldn't come as a surprise to anyone. The only thing new here is a community health assessment project. I have Dr. Julia Kostich's name at the bottom because she's a public health person as well as a lawyer who is doing a crosswalk of all the laws I mentioned earlier. And when we're going to transform our public health laws, we're going to use her work as the basis to do that. Next slide, please. Here I define what I mean by population health. I know it has tons of definitions and tons of connotations. I really need 3 things from this category. And that is population level health education. This is not individual patient level education. It's not diabetes prevention with an individual patient. This is broad scale population health education. Second is partnership development will absolutely be the most important tool in the armamentarium of our public health departments into the future. And lastly is policy and advocacy. Next slide, please. So, This slide's a little bit of a mess, but we had to take our animation out. But the red box will tell you what I really struggled with here in designing the system. I truly believed in our core public health services. I also believed wholeheartedly that we had to refocus on the local level and develop that emergent system that I've discussed earlier. I believe that's the future of public health, both in Kentucky and this country. But what I struggle with is how can I make sure that our locals have the autonomy they need to accomplish this, but ensure there's accountability both at the local level and the state level. And so what I developed is shown on the next slide. And this is a bit of an algorithm for how local public health priorities will be identified and will trickle up to the state level to define the state's priorities in that emergent way that I discussed earlier. And so what will happen is at a local level, your health department will perform a health assessment. That's a needs assessment of your community, like I described earlier. And on that assessment, they will identify priorities. And from those priorities, they will then do an environmental scan. So what I mean by that is if your health department identifies diabetes as a priority, you would then do an environmental scan of your community to ask yourself, who in our community might be available to address this diabetes need? Maybe there's a big physician practice or a hospital or an FQHC or rural health clinic who can meet that need. If there is someone who's already meeting the need or could meet the need, then all we need to do is complement and support them. But if there isn't someone to meet that need, and you as a local board of health, you as a health department, agree that this may be something we need to address, then what you will do is develop an evidence-supported program and submit to a board. Next slide, please. And this is the makeup of that board. Now, the purpose of this board really is to ensure that these local public health priorities are evidence-based and that the solution for them are evidence-based. These are the folks that I have on the board, and you see the CADA president, the Health Department Association president, the local board of health president, so KALBOH president, Kentucky Public Health Association president, all of which are usually 3 health department people. So 3 of the 5 votes on this committee are health department people. The 4th is a university representative, and the 5th is myself as the Commissioner of Public Health. I hope what you see here is not a state board, because it is not a state board. It's an independent board that will help review those processes. Next slide, please. So the purpose of this board is twofold. First, to review and disseminate evidence-based packages to make sure you as Board of Health members have at your fingertips and quick disposal programs that are evidence-based for common public health issues. So let's say you identify suicide as a problem in your community you want to address. I suspect that we will have packages available for you to pull from that will show you here's evidence-based public health approaches to addressing suicide in your community. That's not to hold your feet to the fire to say you have to pick one of these, but it's a resource available to you. And I wanted to make sure that we had that available. And also in my mind, if our health departments are offering 5 services for a common issue rather than 30 services, that allows us to tap into economies of scale, sharing across our jurisdiction, sharing across our county lines, and even combining together for similar funding and grant opportunities. What this board will also do is review those priorities using a 5-point checklist that I have developed. Next slide, please. And this is that checklist. I don't want this board to make value judgments. I don't want them to decide whether your priority is good or bad. What I want them to do is check these 5 boxes. And these are boxes you should be checking already. First is the need that you've identified data driven. Second is the proposed solution evidence supported. It's not to say it has to have a robust level of data, but is it at least best practice? Third, do we have funding? Fourth is do we have a performance management or quality management plan? If we've identified a program that we have data to support the need, there's evidence to support the solution, and we got money for it, how do we know it's working in our population? Maybe it worked in New York City, but it might not work in Harlan County, Kentucky. So we need to be monitoring to see if our uses of our dollars are giving us the best bang for our buck. And then 5th, and this is a little new, is an exit strategy. And what I mean by that is, when will you know that you don't need to do a program anymore? That's not to hold anyone's feet to the fire and say by some certain date we're going to stop our program, but rather is to say, how can we prevent ourselves from just starting programs and continuing them in perpetuity? Just because we wrote a grant and got it 20 years ago doesn't necessarily mean that we should have that grant again today or into the future. So that's something we should be asking ourselves, and we should be constantly assessing. We're constantly focusing, simplifying, and prioritizing our system. That is all I'm asking for here. I know that this board sometimes may seem scary. I'm going to tell you, I already have the authority and the ability to do this from the Department of Public Health level. You guys know I review your budget, and we review your budget. Many of you, your directors, are complaining about your budgets being denied for various reasons. So we have the power to review and approve and deny certain things already. What I'm actually doing is giving up the department's power and giving it to an independent board. And I'm more than happy to do that because I truly believe this is a system that is more sustainable into the future and will be more accountable. And lastly, will prevent us from being in this exact same place 20 years from now. Because we may patch this crisis now, but if we don't set up a system that is more sustainable and more accountable into the future, we will be back in the same place that we have been before. So, I hope I put your concerns about this at rest. Our local boards of health will still have the same power and authority that they have today. Only person really giving up much in the way of authority is me, as the Commissioner of Health, and giving my department's authority over to an independent agency board. Now, what I intend to do is write the language around this board very strictly. Again, I will not let it morph into something that it should not be. Next slide, please. So again, this is not a state board, it's not a public health policy board, they're not going to be writing our legislation, and it's not associated with their funding allocation. They're not going to be doing budget reviews. Next slide. So I'm going to go through some slides about how this system will be funded and the current funding assumptions. As you guys have heard, the budget deficit that exists today is almost $40 million per year. I'm going to show you the way this system, I believe, will fund our public health structure into the future. Next slide. So this slide shows you the entire overview of that core public health box. That is the 4 services that I believe every Kentuckian should have access to. And our foundational public health cost, just that blue box on the far left, costs us roughly $103 million. Our WIC, Women's, Infants, and Children's Program, will cost us roughly $32.7. HANDS will cost us $39.2, and our harm reduction will cost us roughly $9.2, for a total of $184 million. Now, I know a lot of you are thinking $184 million seems like a lot, and it is, and I don't want to downplay that, but when I show you their total public health budget on the next slide, I hope it reassures you that this figure is not all that concerning. So here on the bottom of this slide, you will see all the funding that is currently available to fund this core package. And revenues coming into foundation we have today are roughly $93 million. We have roughly $33 million coming into WIC, $37.8 million coming into HANDS, and our harm reduction is essentially a wash. So we're short approximately $11 million. We're actually not short $11 million though, because this doesn't include $4.1 million in local environmental fees, on-site service fees that many of your health departments have that will be applied differentially. It doesn't include some of the efficiencies we have to find in our environmental services, and they do exist across this state. It does not include a restructure of our environmental fee program, which we are currently undertaking, which will keep more of those environmental fees in the local health department's hands. In my tenure as public health commissioner, we've given 90% of those fees back to you guys. It's my understanding in the past that we've kept up to 30% of those fees, and I intend to keep it at that 90%, or giving you. I intend for us to only keep 90% or 10% and giving you guys 90% of those fees, and we can set that as a recurring rate. The bottom line is that $11 million is much less than that in actuality. Next slide, please. This slide shows you the total funding for our public health system, and I'll just draw your eyes to the totals here. The Department of Public Health has a total funding of $379.6 million. Your local public health systems, through your taxes, your physical court allocations, and your local fees, bring in a total of $181.4 million, for a grand total of $561 million in our public health system. Our public health system has revenues of over $500 million per year. Now, if I, as your commissioner, can't spend $184 million on core public health and come up with that $4 or $5 million that we're short there in this $500 million system, then frankly, you guys should fire me. I truly believe that's possible, and I'm not concerned about getting that done at all. So what I'm telling you is, by focusing our public health system, we can fund the deficits that exist, and we can have the system that I've outlined before that is simple, it's focused, and it's prioritized, and is an emergent system that is led by the local health departments. Next slide, please. The key points that I want to emphasize with you are as follows. I want you to remember that. Simplify, focus, and prioritize. That's the motto for public health into the near future. Our system is going to be emergent, not directed like it has been in the past. Essentially, we're changing the structure to support your needs to a greater degree. I want you to remember that 42 health departments, those shown in red, will face default next year if we don't act. The Department of Public Health, the state's public health model, will have to change. My department will have to change, and my staff knows that. Local health departments will be doing less than they are today. You will no longer be an inch deep and a mile wide. We will no longer ask you to do everything and be everything to everyone. But what we will ask you to do is focus on priorities. Make some difficult trade-offs sometimes. But we're going to expect you to move the public health needle in the areas that you are active. We cannot be afraid to be innovative, and we can't be afraid to take on the challenges that are going to come in public health. The plan I presented you is essentially budget neutral. We took a $40 million deficit and essentially erased that deficit. And so we have stabilized our system financially into the future, barring any unforeseen circumstance. The Department of Public Health, as part of changing our model, will have to find new partners, because we will be funded by the federal government to do some programs that may not be a priority for your health department. That's okay. And there's other people in your communities to help us. I expect our health departments to step up and help us make those partnerships when we need to. But it's okay for us to have some partners in your community that are not our local health departments. That's not a big deal. Next slide, please. So, where we're at today. So at this point, I presented this presentation in some variation thereof to two of our 4 schools of public health, of which we have received overwhelming support. The Kentucky Health Department Association has voted in support of this plan. Your directors have voted in support of this plan, as well as the Kentucky Public Health Association. And we're continuing to spread this message across the state. We also just took this to the Center for Rural Health, has agreed to support this plan as well, because we all think public health needs to be stabilized in the future. Now, what I need to be able to get this done is your support. And I also need a year, because if we have to pay this pension cost this coming fiscal year, meaning if our health departments, those in red, are on the clock July 1 of this year, we're going to be in big trouble. And so I've met with the staff of Chairman Rudy of House A&R, who has agreed with me that this is a big problem and that our public health system needs to be supported. And that if we can deliver this plan, he's going to introduce language into a bill he's drafting that will allow us to have funding for the next year, which means that pushes that a year back and gives us a year to fix this solution. What that means to you is I've negotiated to bring $40 million into our system for the next year to stabilize those counties that are in red, those are the counties that will fall, that will bring our whole system crumbling down. And so I've worked really hard on your behalf, and I need you guys to continue to trust me and support me as we continue to make this transition. But I also need you to join me in advocating to your legislators for this reprieve, because when it reaches the House floor, Senate floor, the committees, we need support. And I know many of you have valuable political connections that can help us along. Next slide, please. And so this is what the timeline looks like. In May of 2018, I performed an advisory committee that would work on this problem. And we've been planning and preparing for this moment in time since then. We've got wide-scale approval from both my department and the governor's office to make this transformation. We've been getting buy-in from our legislators. In January 2020 is when this plan I expect to be brought up before the legislature, because this will take some overwhelming legislative buy-in and redrafting of some of our public health laws. That will not happen this legislative session. What we're asking for this session is our legislators to fix the pension issue, which may mean for us giving us a reprieve to allow us to implement this public health transformation. Now, in the blue at the top, you will see statewide implementation for that timeline. And I have this really starting after the legislative session, but you see a dotted line proceeding even to this time point. Because some of your health departments, those that are in red, need to start making this transition today. You need to start thinking about prioritization. You need to start thinking about all the services you offer and which of those services are data supported. Which of those are the most important priorities for your community? Which of those services can be offloaded to other partners in the community? Do you have a hospital who's already offering certain programs, like diabetes programs, that can be offloaded and reduce our cost? The public health system was estimated to have to lay off 900 employees to make up for this cost. This plan, if implemented, will reduce that by a third to 600. There will be significant changes. Okay, I admit that. But we can reduce the negative impact and focus our model to improve outcomes. Next slide, please. This is a document from Commissioner Leach in 1999. And the title is Mandated Services of the Local Health Department. On the second page, you see he was essentially laying out the same thing that I have before you today. This problem's been coming for a long time. Many people have seen it, and they've tried to make these changes, but for various reasons they weren't able to get it done, often due to the circumstances surrounding them. Next slide. This is a document from 2011 titled Local Public Health Stabilization, where we were trying to do the same thing. Next slide. This is Dr. Davis, 2012. You may not be able to see this on your screen, but the title of Section 1 is Local Health Department Sustainability. Again, trying to do the same thing. Next slide. Let's not be in this same place 20 years from now with someone pulling up this slide deck and saying, why didn't they fix the system? Let's not have people saying, well, they just couldn't come together. Local health departments and the Department of Public Health couldn't get over their vehemence for one another. Let's come together and fix this system. Let's make it sustainable for my children, your children, our grandchildren, and into the future. And let's move the needle. Let's not be 45th anymore. We're paying 26th per capita. Let's get 26 results. I believe that's possible in Kentucky, but we got to come together to do it. Next slide. This is what I believe we can achieve. I think it's radically different than anything we've done in public health, and I think it'll be the model for public health across the entire country, and we can lead that change. Next slide. So at this point, I'll take any questions. Thank you guys for your patience and listening to me rant for 30 minutes.
Do you have any questions? No questions have come across yet, so we'll go ahead and get Glenn Mays up. And you're going to stick around, right?
Yeah.
Okay. Glenn, are you ready?
I'm ready.
Come on up.
I can't believe I had to follow Commissioner Howard.
Wasn't that amazing? Good job. Good job.
That wasn't me. That wasn't.
So Glenn, just sit down and we'll get the camera focused on you. You'll see your presentation here, and when you need a slide change, just let Greg know.
Fantastic.
And introduce yourself if you don't mind.
Absolutely.
Thank you.
Well, good evening, and thank you for letting me join you for this event. My name is Glenn Mays. I am a professor of Health Services Research at the University of Kentucky in the School of Public Health. I have the dubious distinction of having to follow Commissioner Howard in that amazing presentation about the future of public health in Kentucky. And I think maybe why I was asked to be in this slide is because I've actually spent a big chunk of my career, more than 20 years, studying the work that you all do, studying public health systems, how they're configured, how they vary, and importantly, studying the impact of public health systems, the health and the economic impact of public health systems. So I think what I can do is share with you a little bit of the research that suggests the kinds of health and economic outcomes that we can achieve in Kentucky by implementing the kinds of reforms and innovations that Commissioner Howard just laid out for you. So that's what I'll try to do in the next few minutes. Next slide. And so Commissioner Howard talked about this concept of population health, and I know that all of us in public health have been thinking about this frame of mind and thinking about what public health agencies can do to achieve improvements in population health. And the way that we think about this concept is that by population health, we're trying to achieve large-scale health improvements, improving health status for entire communities of people. And not just improve the overall health status, but also reduce variation in health status or tackle inequities in health within key subgroups of our populations. We know if we want to do that, we've got to target fundamental determinants of health and multiple determinants of health, far outside the walls of our clinics and our medical care systems. And then finally, to do this, to move the needle on population health, there's no one organization in the community that can do this work. Health departments can't do it alone. Hospitals and clinics can't do it alone. So we know this is fundamentally about mobilizing collective actions, getting a whole range of organizations to row in the same direction around improving health status. So that's largely what we're trying to do, and I know that's what health departments and increasingly boards of health are trying to do. Why do we need to do that? Well, Commissioner Howard laid out a lot of the challenges that we're facing in Kentucky, and we're facing these challenges nationally as well. We've now seen 3 straight years of declines in life expectancy for the U.S. population as a whole. We never thought we were going to see this in the 21st century, and so this is just another signal that it's time for a change in terms of what we do in public health. Next slide, please. We also know there's enormous inequities in health status as we move across states and move across communities, even move across zip codes, and the drivers of those inequities are many and varied, and so. There's a moral imperative to kind of reforming our health systems in ways that can tackle inequities in population health across communities. We also know that, again, if we're going to improve health status on a population-wide basis, we've got to tackle multiple determinants of health. We've got to deal with certainly the major behavioral drivers of health and well-being. We've got to improve access to and quality of health care. But we also have to intervene on social and environmental determinants that are major drivers of health and well-being across our communities. And as Commissioner Howard laid out, our current public health agencies across the state are not well organized and configured to do that kind of work, to achieve broad-scale population-wide health impact. And in fact, it's not just that our public health sector is not well configured for that. It's also true that our medical care systems and our social service systems are also not well configured to work together around improving population health. We've got enormous fragmentation across public health, medical care, and social services. And this is one of our major gaps that we have to tackle. It's not just that our local public health agencies don't have all they need to do this work, but it's also that our public health agencies are not optimally connected to the other organizations in the community, medical care, social service organizations. That we're not well connected in ways that can achieve improvements in population health. So we've really got to think about the problem, and another way of thinking about the problems that Commissioner Howard laid out is think about these as collective action problems. Again, the health department can't move the needle on the health status by itself. So we've got to figure out how the health department can better connect all the organizations in a community, get them all aligned, rowing in the same direction around improving health status. So looking at how we can align the incentives that that these different sectors are operating under. Looking at how we can get a better balance on the costs and the benefits of doing public health work across communities. Addressing gaps in information and uncertainties about whether we're doing the right things, whether we're making progress as a public health system. So these kind of collective action problems are things that we need to solve. And really, boards of health and communities are ideally situated to think about these kind of collective action problems. How do we get organizations in the community working together, coordinating productively around improving health status? To do that, we actually have a lot of research that points to evidence-based strategies that can help us solve those collective action problems, get organizations productively working together around improving population health. And these strategies, which are shown on this slide, we've called these kind of strategies various things over time: core public health functions, foundational capabilities. These strategies are actually the same strategies you just heard Commissioner Howard lay out in his plan for reforming the public health system here in Kentucky. We've got to have mechanisms for engaging stakeholders, for assessing health needs and risks at the local population level, for mapping those needs and risks to evidence-based actions that can address those needs. We got to have mechanisms for priority setting and planning, because we can't tackle all the problems at the same time. We've got to have mechanisms for figuring out roles and responsibilities and fitting resources to those roles and responsibilities. We got to have mechanisms for coordinating the implementation of evidence-based strategies across the different organizations that are implementing in communities: public health, medical care, social services, public and private sector. And then finally, as Commissioner Howard mentioned, we got to have performance monitoring and evaluation mechanisms in place to give us feedback about, are we moving in the right direction, and to help us make mid-course corrections over time. These are the kind of things that decades of research across the country have shown are effective in solving collective action problems and moving the needle on population health. So I'm going to share with you just briefly some of this research that can tell us, first of all, how we can measure the strength of our multi-sector public health delivery systems around the country, and then what kinds of health and economic outcomes strong public health systems can produce in our communities if we can achieve the kind of reforms that Commissioner Howard laid out. Just a little bit about how we do this research. Again, I lead a research center at the University of Kentucky called the Center for Public Health Systems and Services Research. Believe it or not, we got a whole research center that does nothing but study the kind of work that you all do in communities and local boards of health here in Kentucky and across the country. Part of what we've done is we've maintained over time a national surveillance system that measures public health systems across the country. The range of activities those systems produce, the range of organizations, public and private, that contribute to those systems, called the National Longitudinal Survey of Public Health Systems. Some of you have probably gotten a survey from us, and we do the survey every 2 years, both here in Kentucky and across the country. We follow about 600 communities across the country. And I've been doing this for 20 years. This past year was the 20th anniversary of this survey, to study public health systems, what they look like over time, over 20 years. And by taking this data and linking it with lots of other great data that we collect in public health, like vital statistics data, mortality and behavioral risk factor data on healthcare expenditures, we can do strong studies that show what happens to health status when public health systems get stronger, do more of those core foundational activities that I talked about. So I'll show you about that. So we link our survey data with lots of other data sources, like the ones you see on this slide, to be able to do strong, robust studies to look at, not just describe public health systems, but actually estimate the causal impact that public health systems have on health status and on economic outcomes in communities across the country. Next slide. One of the things we can do with our data is actually visualize what the structure of public health systems look like at a given point in time in communities all across the country, using network diagrams like the one you see here. This allows us to visualize the different organizations that are playing different kinds of roles in supporting those core public health activities in communities. And what you see here, it's not just governmental public health agencies in this network, although those governmental public health agencies play a large role. But you've got hospitals, community health centers, physicians, faith-based organizations, health insurers, schools, universities, and others playing a role here. And the connection points, it's not just the size of those different organizations that makes a difference here in terms of the size of the role those organizations play, but the width of these lines connecting different organizations is also a key piece. How strong are the ties connecting different organizations that are a part of our public health system? Or in other words, how often do these organizations work together in producing and implementing core public health strategies? Turns out that's a key part of the success of public health systems. So we've come up with a way of classifying public health systems around the country based on the strength of their systems. A clinical classification, if you will, just like we type diabetes and cancer, we can type public health systems based on their characteristics and strengths. And in particular, we look at both the scope of core public health activities these systems are able to support collectively, how many of those nationally recommended foundational activities these systems can support. And we also look at the density of the network, how many different organizations play a role in supporting those activities, and the density of connections that are connecting public health agencies with medical care organizations and social service organizations and employers and schools and other actors in the system. The strongest of these systems, according to our typology, are what we call comprehensive public health systems. These are systems that support a broad scope of those foundational activities, the same activities Commissioner Howard just talked about. And these comprehensive systems, they not only support a broad scope of activity, but they do so through dense relationships between among organizations, multiple organizations in the community who are playing a role in supporting those activities. If you meet that definition, you're classified as a comprehensive public health system in our data and research. This is another way of looking at comprehensive. How we define comprehensive public health systems. They implement a broad scope of these nationally recommended foundational public health activities. Same activities Commissioner Howard is stressing, and they do so. They support those activities not by expecting just the local health department to do all that work, but they bring in a broad, dense network of collaborating organizations to support those activities. Next slide. Just a note that some of our research looking at public health systems is funded by the Robert Wood Johnson Foundation. Many of you know that foundation. It's the largest philanthropic organization in the U.S. that is dedicated solely to health and public health work. Some of you know the foundation has launched a 30-year effort to build a culture of health across the U.S., strengthen a culture of health. They're using a small set of metrics to track progress over time toward achieving a culture of health in the U.S. And this definition of a comprehensive public health delivery system is one of the core metrics the foundation is using in tracking progress over the next 30 years in building a culture of health. How many people in the U.S. are covered, live in a community that has a comprehensive public health system that meets those definitions. So this is one of our national metrics now for tracking progress over time. If you look at our data over time, either in Kentucky or in this slide kind of shows you the national progress. We are making progress over time. Over the past 20 years, larger and larger shares of our communities are able to achieve that status of comprehensive systems, but still, we're still just a little over a third of communities have reached that status of comprehensive systems. So we still have a lot of room for improvement. And Kentucky, this is just showing you the national average. Kentucky, we're a little bit below that norm. We're closer to about 30% of communities across Kentucky meeting our definition of a comprehensive system. And as you can see, there is a bit of a rural-urban disparity in comprehensiveness of systems. Rural communities are substantially less likely to meet that definition of a comprehensive public health system. But even in rural communities, we're seeing it's possible to make improvements over time. So what difference does it make? What kinds of health outcomes can we expect to achieve from communities being able to meet that definition of a comprehensive public health system, supporting a broad range of those nationally recommended activities through dense collaborative networks of organizations? This is work we published about a year and a half ago now by tracking changes over time in our national cohort of communities and looking at the impact that of comprehensive systems have on mortality, one of our most important measures of population health, both overall mortality as well as mortality from preventable conditions. And as this slide summarizes, looking over about a 16-year period, communities that moved to crossing that threshold of becoming a comprehensive public health system, overall saw about a 9% reduction in all-cause mortality, all deaths from all causes, compared to communities that were not able to achieve that comprehensive system status. So that's a large impact on overall mortality. If we look at several specific types of deaths from preventable conditions like heart disease, diabetes, cancer, we see even larger effects on mortality. We see about a 15% reduction in heart disease mortality for communities that over time can cross that threshold into having a comprehensive public health system. Similar decrease in diabetes mortality and cancer mortality. So there are real large health effects that we can attribute directly to the structure of our public health systems, exactly the kind of things that Commissioner Howard is trying to move us to. And these are we can attribute, this is not just associations, these are causal estimates of the impact of strong multi-sector public health systems on mortality. Next slide. We've also been able to show meaningful economic benefits that accrue to communities over time when they're able to make progress in building a comprehensive multi-sector public health system. This is work we published just about 6 months ago, looking at medical care spending in communities over time, and what happens over time when communities move to crossing that threshold of meeting the definition of a comprehensive public health system. Overall, we see about an 8% reduction in medical care spending per person for communities that achieve a comprehensive public health system compared to other communities over time. So 8% reduction in medical care spending per person. That translates into potentially billions of dollars annually across the country, given that we're spending over $3 trillion per year on medical care overall. So this shows us there are real large economic benefits that can accrue to communities and to society, largely by reducing the need for costly and potentially avoidable medical care if we have a strong public health system that's doing its job in preventing disease and injury and mitigating the preventable determinants of health status. So real economic benefits that we can trace right back to the structure of our public health systems locally. Next slide. This is some of our most recent work looking at the impact of public health systems on specifically on equity and health status. And here we've looked at life expectancy in communities over time, and in particular life expectancy by income, because we know that income is a major determinant and socioeconomic status is a major determinant of health status. So using the same data that I've showed you and the same kind of design, tracking communities over time, this time over about a 14-year period, we've looked at what happens to life expectancy for the bottom 25% of the income distribution, or life expectancy among low-income populations compared to higher-income populations over time. And what we see and what the slide summarizes is that over time, over about 14 years, communities that move to meeting our definition of a comprehensive multi-sector public health system see about a 4-year gain in life expectancy for low-income populations, the bottom 25% of the income quartile. Those are low-income and moderate-income working class households in our communities. A 4-year gain in life expectancy, real health impact, and a disproportionate impact on the highest risk, lowest income segments of our community. We also see a gain in life expectancy even among the top 25% of the income distribution as well. Almost a year gain in life expectancy for our most successful, our highest socioeconomic status population as well. But as you can see, the largest gains accrue to the kind of the highest risk population. So overall, what that means is communities that over time move to meeting a definition of a strong, comprehensive public health system, we are able to reduce the disparity in life expectancy between high and lower income populations by 3 years. Cut that life expectancy difference, that disparity in life expectancy by 3 years over time. So again, real meaningful health impact that we can attribute back to public health systems doing the kinds of things that Commissioner Howard is trying to spur us to doing, and a real equity, an impact on health equity directly, reducing disparities in health status across key segments in our population. And so this is just another way of looking at the fact that everybody gains across society when we strengthen public health systems, when we build stronger public health systems. but those in the but low resource communities and low resource populations benefit disproportionately. They especially benefit from strong public health systems, and so that's the equity impact that public health systems are able to achieve in the community. So hopefully this has showed you again that there are real, quantifiable, research-tested, evidence-based outcomes that are attached to the kinds of reforms that Commissioner Howard is pushing us toward. Doing the kind of things that we've been recommending, that national bodies, the National Academy of Medicine, the American Public Health Association, and others have been recommending for a couple of decades now. If we can find a way to build systems that will do those things through public health agencies and all of our partners, these are the kind of benefits that we can expect to achieve, and that will absolutely move us up the rankings that Commissioner Howard was talking about. This will move us out of the bottom 10 states, and over time help us lead the way toward a healthier society. So how do we do this work? And again, what I've been showing you, the things that we measure and the kind of benefits here, again, we're not just looking at what governmental public health agencies are doing. We're looking at what the entire system is able to do collectively. But I would say governmental public health agency and boards of health in particular have got critical roles to play in building that system. Some of this work, some of these activities your health departments are going to do directly. But a lot of this work, you're going to be steering the boat, not rowing the boat. You're going to be convening those stakeholders. You're going to be helping communities priority set, helping them figure out divisions of roles and responsibilities. Who's going to do what? What's the hospital going to do? What's the medical society going to do? And you're going to be a key part in kind of measuring success and holding these different actors accountable. And you're going to have to play a role in making sure we've got sustainable financing for not just the public health agency, but for this larger constellation of organizations that represents the network. And I would say governance, boards of health are essential in helping to weave together a sustainable financing model for these kind of multi-sector networks and approaches. Keeping organizations at the table. As governing board members, you've got connections not just to the health department, but to all these other entities, the Chamber of Commerce, the schools, the employers, and others. You're in a unique position to keep these people at the table, keep everybody playing a role in financing the kind of strategies that work. So in conclusion, hopefully what I've been able to convince you is just to add some support to the kind of direction that Commissioner Howard is trying to move us in, and in particular to reassure you there are real, tangible health and economic gains that we're going to realize by strengthening public health systems in our communities here in Kentucky. Real health gains, real reductions in deaths, and reductions in medical care costs. That means keeping more money in the pocketbooks of our households and our communities, and being able to invest in other kinds of things because we're not having to invest in treating preventable diseases and injuries. And the other real benefit here, I was able to convince you that that we're also going to be achieving health equity goals by doing this, because we're automatically going to be the people who are going to benefit the most are going to be lower income and high risk populations. And so this work is really important. This will produce real impact. And the more challenging news is that we've got most of our communities do not have comprehensive public health systems in place right now. That's true here in Kentucky, and that's true across the country. So we've got a lot of progress to make. That's the challenge, but that's also the opportunity. That means there's a lot of health status gains that we can achieve. Lots more people living years longer than they are today because of the work that we're doing. And again, governing boards, you all who are the governance and decision making and strategy setting bodies for not just our health departments but for our communities, you all are in a pivotal role to help make this transition happen, in taking advantage of the policy environment, the kinds of incentives that exist, public sector and private sector, all of this work, I think, is critically important, and really, you all as governing boards are pivotal to these kind of changes. So. So hopefully I've hopefully kind of maybe added some evidence to the work that is already underway here in Kentucky, and that many of you are already planning and positioning to do. Remember, it's not about the power of your agency alone. It's about the power of the network. You need to think about using the power of the network and doing the things that strengthen not just your agency, but that strengthen the network. What are those things that strengthen the network? Those are the things that Commissioner Howard laid out: assessing, planning, priority setting, implementing core functions, and evaluating and monitoring and continuously improving over time. So, with that, I think I will stop.
If there's one more slide, are you good? I have a question
Okay.
from the field. Is there research in the connection between accreditation of local health departments and comprehensive public health systems?
Yes, there is. Great question. We're finally starting to build a body of evidence around the impact of public health agency accreditation. Those accreditation standards, if you know about them, you know that they are tied to many of the activities that Commissioner Howard mentioned, and they're tied to many of the activities that I mentioned that we measure in our study around community engagement, assessing, priority setting, and planning. So not surprisingly, health departments that are able to meet those accreditation standards, that takes them a lot of the way forward in meeting in having the attributes that we look for in strong, comprehensive public health systems. In fact, we published a paper just earlier last year in the American Journal of Public Health that shows that looking before versus after national accreditation standards were rolled out, it shows that accreditation has had a meaningful impact in moving more communities toward meeting that definition of a comprehensive public health system. So it's absolutely an important part of the solution in strengthening systems.
And Glenn, I have a question. This year, 2018, Kentucky participated real significantly as all of our members participated in the survey. What were some key takeaways from that, and can you just give us some Kentucky?
Absolutely, yes. And so we're grateful that we did get really statewide participation in the survey this year. We've enhanced the sample so we can really study Kentucky on a much more detailed basis. And so those results will be rolling out here in the coming month. But certainly, some of the key takeaways is that we are making progress. We have seen gains in communities that are moving toward comprehensive public health system status in Kentucky. More communities approaching or meeting that threshold, which shows that it's possible to put these kind of capacities in place, even in smaller and low resource communities across the state. So I think that would be one key takeaway. And the other is that there's not just one way to kind of to build a strong system. There's lots of, every community is a bit different in terms of its resources, in terms of its organizations, and how roles and responsibilities are divvied up. And so I think that's another key takeaway. When we look at the comprehensive public health systems here in Kentucky, they all look a bit different in terms of what roles are being played by public sector versus private sector, by healthcare organizations, employers and schools, and others. And so there's not a one-size-fits-all model. And I think that's also that strongly supports the kind of Commissioner Howard's approach of thinking about the need to build emergent systems that can emerge based on capacities and needs that exist at the local level. We see that in the Kentucky data.
And so one last question for me. As it relates to all of us participating in 2018, we clearly have laid the foundation of a starting point for implementing the transformation plan, and we'll be able to, if we all continue to participate 2 years, 4 years, 6 years, we will have laid the foundation for 2018 to say this was our benchmark moving forward, correct?
Absolutely. By having statewide participation, we've got a system in place to track progress over time. You've got a good, strong baseline in 2018. We know what our systems look like here in Kentucky. And we're in a great position to track that over time, and also to learn from each other, to look at the communities that have made gains over time, and let's figure out what they've done to bring more organizations into the system, to bring more resources into the system. We can learn from each other when we've got this kind of information that cuts across the state.
Okay. Are there any other questions from the field? Any questions for Dr. Howard? Thank you, Glenn.
Of course. Thank you for letting me join.
I'm very excited that we've got Kentucky baseline data for our transformation plan, so looking forward to seeing the results.
Absolutely.
Do you have any questions for Dr. Howard in the field? Okay, I have a question that was submitted earlier that I just want to ask Dr. Howard about. Bring you back up here. There were some questions that were submitted to me, Allison Adams, prior to this presentation that I'm going to make sure gets completely answered. But one that I've chosen that for relevancy is just for clarification, Dr. Howard, local health departments will have to use 1.8 cents of the foundational services before receiving any federal or state funding.
So the system that we've designed to make this public health system function in terms of funding is we tie the first 1.8 cents in local tax dollars to the foundational services. Now what I will tell you is I think it's all but two, correct Mike, all but two counties are already putting their full first 1.8 cents into this service. So for 118 of you, this is not a change at all. For 2 of you, which is 2 of our more wealthy counties, will be putting a little more of your local tax dollars into foundational services than you have been in the past. Again, for the vast majority, more than 99% of people on this line, that is not a change at all.
And then the other question, I think you addressed in your presentation, but just for clarification, what will the role of the local Board of Health be moving forward?
The local Board of Health's role will be the exact same as it is today. You will still have authority locally. You will still be driving your own priorities. But the only difference is instead of exercising the oversight capabilities through the Commissioner of Public Health, really through our budget review process, we'll be exercising it through an independent board. I think this is very important. One reason is this board is not subject to the political whims of whoever's the person in office during that year. It'll be an independent board who can really put Kentuckians' health first and foremost. And second, we've designed a system that really reins that board in and really has them checking boxes that we already should be doing anyway. If you really take a hard look at what we're introducing, it's really nothing new for most people, but it's just a different way of thinking about and approaching our public health system. Anything else? Again, thank you guys.
Do we have a question on the mic? No? I saw her hand or something too. You want to come back on? Thanks. You gonna do it? Can you get us both on? All right, so that concludes our meeting. I want to thank Dr. Brian Andreas, our current Vice President of KALBOH. For those of you who don't know me out there, I'm Allison Adams, the President of CADA. A couple of take-home messages, I think, for KALBOH, you all as Board of Health members, is the role that our Commissioner has chosen in the Oversight Board as it relates to the KALBOH leadership and how important it will be involved to get involved in the Kentucky Association of Local Boards of Health. Currently, we have 30 boards of health members of KALBOH. There's 120 of us out there. So I just encourage you with the elevated role of local Board of Health presidency, KALBOH presidency as part of this oversight, being involved in KALBOH and knowing who your representative is vital. And I'll say the same thing for the Kentucky Health Department Association and my colleagues in the Kentucky Public Health Association. Now is the time to get involved in these organizations that represent you as directors, as boards of health, and as public health employees to assume leadership position, be knowledgeable of who's on the ballot, who are you electing to represent you in this oversight capacity, and having that connection. It's not just about having connections within your community, but also in our statewide organization. So some upcoming things that we're excited about in KALBOH is we are looking for paid executive leadership, a partnership with our Kentucky public health organizations, so that we can have you, for local boards of health, a committed person to moving the organization forward, building its capacity and representation across the state in advocacy and in our legislative process. So we'll be reaching out for its membership. Starts January, so we're right now in the middle of our membership drive. So again, if you're interested, you can contact me or Dr. Andreas right now as the representatives of KALBOH, or please reach out to your health department director. They know how to get in touch with me. We can get you a membership application, and if you are interested in assuming leadership, committee roles in KALBOH, we are more than excited to have you on board. So please reach out to us. It's more important now than ever to be involved. So
yeah, I've been, involved with KALBOH and with our health department for at least 15 years, and I'm very excited about what the commissioner has offered, getting KALBOH more involved, and I think it's extremely important. Because that needs to come from the local level, and it's a chance for us to have a lot more input than we've ever had before. So again, please look very hard at joining KALBOH, get involved, and help us move this state forward.
So again, thank you all for your participation. Safe travels home. Stay warm. Those of you who are joining us in the comfort of your own home, I hope you were able to get connected and no issues. I want to thank, you can't see him, I want to thank Greg Ramey. Without his technological expertise, this wouldn't happen. I'm the least technological person, so I beg and plead every year. And thanks to Dr. Georgia Heiss, because Greg is on her staff, for allowing him to assist us tonight on her dollar. So thank you to Georgia for doing that for us. Again, this is an annual event. We'll see you again next year, but as a result to KALBOH, please be looking forward to some more regular meetings and regular communication from KALBOH moving forward. So thanks, stay warm, and safe travels home.